Hello and welcome to the Brand Ramacco podcast. I have with me today a Tom Swales, a physiotherapist and strength coach. He is the creator of the Advanced Movement Therapist, the AMT certification for physiotherapists and movement therapists.
Yeah.
So is it just physiotherapists or do chiropractors can take that too?
We put chiropractors have gone through, athletic therapists, massage therapists, personal trainers. It's really anybody who works with, humans, helps them out of pain and wants to get them moving a little bit better, a little bit faster.
Okay. Maybe before we jump too much into the details, thank you for being on the podcast.
Thanks for having me, Brandon.
And if you can, let us know, sort of where you come from and how did you get into, like, what inspired you to create a system to help people?
So it really comes, like most interest, it comes from our own problems. People who become experts in a specific health condition is because they've gone through it or because a loved one has gone through it. So they became experts in that field to help them and help others who have gone through it. So my frustration came from, coming out of doing the master's program of physical therapy. It was great. And what the traditional schooling taught us is about the pieces. They're like, okay, you have a shoulder pain. Here's your anatomy. Here's the mechanics. Here's how we diagnose. Here's our clinical prediction rules. Okay, great. Well, now we know it's a grade 2, supraspinatus tear. What do we do? And most of the time they're like, okay, well, get in friction and massage and ultrasound. And okay, well, what caused that? So because there are so many other pieces that connect to the shoulder. Well, what's the cervical spine doing? Can it rotate? Can it side bend? Is there nerve innervation issues? Is there nerve compression? What's someone's breathing patterns? Because if someone's breathing like this all day, well, what do you think they're doing with their shoulders? They're using their shoulders to help them breathe. What's their thoracic spine? What is the rib cage? Can it extend? Can it rotate? What are the scapula doing? What's the core doing? Because if you're side bent, that's not helping your shoulders. What's your pelvis doing? Do you overpronate on one side of your foot? Because that's going to cause a pelvic collapse. Now there's this core inhibition from foot to hip to, that contralateral side. So they show you the pieces, but they don't show you how to put it together. So my frustration came on more with, I right out of school, I'm like, I got to go do my advanced manual therapy and manipulation certification. Okay, great. Let's go learn manipulations and needling and I did over 100 courses. I do the osteopath stuff. I did kettlebells. I did gymnastics. I did it all. And they're all great tools. And they provided solutions to very specific problems when you could figure out that was the problem. The more I learned, the more I realized I didn't know. And the more I learned, the more I forgot. And then the more courses I took, I'm like, well, I took this course this month, so everybody gets this month because it's the flavor of the month. Now I was just guessing, and I hate guessing. So I started looking at kind of what do we do as clinicians? Like, what are the fundamental principles? And I kind of distilled it down into 5 principles, that being psychology, neurology, biology, chemistry, and physics. So the interaction that we're having right now, it's communication. Well, do I feel safe with you? Do I like you? Do you feel safe with me? If there's a yes to those, okay, great. Your nervous system's automatically going to start to calm down. We're going to open up, right? The patient's going to open up to me. They're going to let me in. Okay, great. Now we look at neurology. How are they moving? What's their motor output? How are they organized? What's their posture doing? Because that's our feedback loop. So we look at movement, muscle testing, that's your neurology. And it gives you that feedback loop of effectiveness. And then we look at biology. Well, how do tissues repair? How do we organize from an embryological perspective? What's priority? Where is our energy systems allocated, right? Like the brain and the nervous system take up 25% of all the glucose, 30% of all the oxygen, but 2% of the mass. So guess what the nervous system is going to prioritize? Well, those structures over shoulder. So if you've got nerves that are getting pinchy or compromised or unsafe, well, your body's going to sacrifice the shoulder to protect the nerve. And then you look at chemistry. Well, being in the hospital, I realized that was kind of the pillar that I was missing. It's like if your CO2 is too high and your oxygen is too low, you go acidic. Well, what does that create? It creates inflammation. It also pushes our nervous system to the sympathetic state, fight or flight. We can't digest food. We can't absorb oxygen. We can't, absorb nutrients. And then the last one's physics. Now, this is where it kind of started making sense. When you see these practitioners and they're doing this magical stuff, you're like, how did you do that? How did you get there? and they would explain it from a traditional Chinese medicine. They would explain it from a very mystical perspective. And I had one of those mentors, and I'm like, this is awesome, but I do not know what you're saying.
Yeah.
And then I learned physics. I was like, oh, this is what he's talking about. So when you look at quantum physics, more specifically, it's everything's vibration, frequency, and energy. And then as soon as you start distilling and looking at things like that, well, molecules are vibrating. Everything has a specific frequency. Thoughts create vibrations and frequency that affect matter. So now you know, okay, well, if a thought can either heal my body or hurt my body, well, then that's sending out a specific frequency to my biology, which is responding to that in a very specific way, either positive or negative. So going out and trying to distill down what exactly do we do? It came down to those 5 elements. And then I figured out how to organize it in a basically a systematic approach of like the first interaction, have a conversation, look at posture, look at global movement, look at how the system moves first, and then look at the neurological system, and then start breaking out some of the pieces. So I organized it in a kind of an algorithm. And I realized, I know people don't want to hear, oh, algorithms are very cookie cutter. No, everything's an algorithm. When you see somebody, a veteran clinician, get to a problem or come to the solution really quickly, they went through an algorithm in their head. They've done it and seen it so many times that it looks like magic to the outside person. But they literally went through the algorithm of da-da-da-da-da, and sometimes they have shortcuts to get there. But when we're newer at this, we have to go through everything. And then the more practice we go, you can get to the solution faster. Everything's an algorithm.
But you can't jump to the shortcuts without understanding.
No. Yes. So you need to, it's like, you're not going to go get your knee repaired by a surgeon that was just like, hey, go figure it out. No, that surgeon's going to learn it from a better surgeon, right? And then when he's done it that way so many times, he can be creative. Now he's like, okay, I've mastered this algorithm. Now I can find shortcuts and better ways to do it. So I think too often we get caught into I want to be creative on the front end and get to a different solution, or just get really good at some kind of fundamental system that's organized. And then you get to be creative once you've gotten really good at that. That's where the creativity comes in, is on the back end of treatment. You know, if you're consistent on the front end, you won't miss any of the important pieces, and you're not assuming anything. And then now on the back end, you've got all the information that you need, and then you can find the priority of what you need to treat to actually get the person better and keep them better.
So I have a few things to add and to get your input on.
Sure.
Actually, there's a lot of bad physiotherapists on island, for sure. There's some good ones too, but
good and bad everywhere.
Yeah, always true. And I ran into some bad ones in Canada. Which is why I left. One of the reasons why I left. So soft tissue work, it's a lot of symptom relief. And chiropractors are known for this too. Symptom relief, symptom relief, symptom relief.
Yeah.
And, you know, the soft tissue massage, the e-stim, we'll put you on the TEMS machine, we'll put a hot pack on you. We'll use the therapeutic ultrasound, which of course the evidence, meta-analysis, systematic reviews, feels good. But not going to get someone better for the majority of pathology. Yeah. And not going to keep them better regardless.
No.
And particularly on island, I saw a lot of people not get a single exercise. And of course, there are problems that they had a big limp. They couldn't raise their arm above their shoulder. Yeah. And they basically were sentenced to, well, until they ran into me, maybe a lifetime of pain without relearning how to control the nervous system, the mind-body connection, which is part of healing and, I guess, protecting and maintaining the body. You can't do it without proper control. Yeah. And you mentioned, we've been talking about recipes. And or actually, have you seen that too? That some physios just focus on the soft tissue pain relief, and then just and patients like it. Oh, it feels good. They go back.
Absolutely. Back. Human touch is very powerful, right? When you're looking at embryology, you look at those germ layers, and you look at the ectoderm. Well, it composes the skin, the dural tube, and what's the other one? So skin, dural tube, and some of the organs. So you have these layers. So human touch is very powerful because I can touch somebody, and me as the therapist, being kind of at a lower charge or a less sympathetic state, just my hands over the area is going to make it feel better. You're stimulating touch receptors. It's going to block the pain receptors. Touch is very powerful. It needs to be done, yes. But what we need to understand is touch is temporary unless you change the behavior of movement afterwards. So you get the adjustment, you stretch the tissue, you use your modality. Oh, wow, my shoulder feels greater. And then they leave. Well, it's going to come back in 48 hours because that manual reset that you just did, because that's what you just did, is you calm the nervous system to reset the system. It's going to come back because their movement behaviors haven't changed. They're going to keep stressing and overloading those tissues, and then they're back on the table. Unless you teach people how to move differently and move better, they're going to keep coming back. So manual therapy, it doesn't matter unless you add movement. They have to go together.
Yep.
And sometimes if there's no pain, you just get people moving. But if there is pain, yes, we have to settle pain because pain will change behavior, and behavior is movement driven. If I don't want to perform this certain movement, my body's going to create compensations to move around that pain as much as possible, because pain is a signal for change, and also the nervous system looking for survival and avoiding that. So I need to make them feel safe to want to move into that range of motion, but then I need to teach them how to do it on their own. Which is, okay, let's put them in different positions, postures, get them to feel those muscles. Okay, let's do some isometrics. Now let's give you a kettlebell. Hold that in the air. Oh, now we've got all the stabilizers from hand all the way down into our pelvis, locking in and organizing together. And now all of a sudden, oh, my shoulder pain's gone. Amazing. And I also say, I'm like, you have to practice this because you will default to your old bad habits. So the practice and the repetition has to come in. Of course, we always not into pain. Your breathing changes, can't feel the muscles, or you start to feel pain, practice is over, right? Because now the nervous system's starting to get fatigued. Okay. But what we try and emphasize at our facility, because we have one half of the clinic is we have modality rooms and private treatment rooms. And then the other half is a full gym. It's over 2,000 square feet. It's mostly open floor space. We have monkey bars, balance beams, kettlebells, all the fun stuff. And what we tell people, I'm like, this is the side where you feel better, but over there is where you get better. If you don't do that, there's no point in doing this. And for people who want just, oh, I'm going to lay down and you're going to fix me, I'm like, this is not how this works. That you won't get better. And we attract we're fortunate because that's what we put out. We attract a very motivated population. They want to know the why. They want to know the tools on how to get better themselves. And then we teach them how to do it. And then they're 100% happy. And that's fun, right? It's not the best business model to keep them coming back. But they're humans. They're going to go hurt themselves again doing something else. When somebody comes back, I'm like, is this a new injury? They're like, yeah, okay, good. I don't want you to come back for the same thing that we fixed before, because then we didn't fix it. Right? Or we didn't help you fix it. Go ahead.
So I tell people all the time, I hope very soon that I'll never see you again. In a good way. I don't want to see you here again in a good way. I want to see you on the street, wave at you. I'll see your family members if someone's injured. Hopefully you don't injure yourself, but if so, but I do not want to see you in here again in a good way.
Yeah. And that's the point. Like that's job satisfaction. It's not, I've worked at places where it was just this revolving door and you're seeing the same people over and over, and your schedule's busy, and they keep coming back because they like you and you make them feel good, but that's not making change. Like, the point of doing this is to change people's lives, and it's not changing people's lives if they keep coming back depending on you. We're just creating more dependency. And when we have dependency, they have no power. Now they feel like, I can't live without you. Well, that's a terrible place to live, because now you can't manage yourself and you're not very resilient. And then if all of a sudden I can't see you, you fall apart. You're like, things are terrible. And that's not where we want people to live.
So your business model reminds me of, now you're in Canada. There's a couple larger chiropractic chains. Well, there's one huge one and one smaller one, and the smaller one does hire physiotherapists and chiropractors. And they often have to retrain the chiropractors depending on what school they come out of.
For sure.
So the big chain is The Joint. I think they have locations in Canada soon or starting up. And you go in, it's like $25. You get your chiropractic adjustments. It's just a big bay with tables. They're not supposed to treat any pathology or pain. They're supposed to only treat stiffness or That's their business model. They've been
That's
sued a few times
interesting.
for that.
Oh, that's so odd.
Oh,
That's an
because
odd
it's
business
5 minute
model.
visits.
Right. Yeah.
Yeah. So they're supposed to. It's supposed to be you're getting like the patient is self choosing the therapy,
Sure.
top to bottom chiropractic adjustments. There's no real assessment. There's no follow up. There's no.
So that would be like, um, I want to build a house. I'm going to hire an expert who knows how to build houses, and then I'm going to get in the way and tell them how to build it.
Yeah,
It's not going to work well. Like you're,
it's a waste of the schooling too.
people are paying us a lot of money for all the knowledge that we need to
Yeah,
give them. Anyway, that's just,
it's a business model.
it's a business model. We'll just call it that.
Yeah, they make a lot of money.
Yes.
There's another business model, Arosty.
Mm,
They only do 1 hour sessions. Only
right.
option. They
Right.
have research to support that on average now their claims are a little misleading when you look at their own research.
Sure.
Yeah,
Yeah.
but they claim we get people better in 3.4 visits. Yeah,
Mm.
but
It- so any good clinician can get rid of somebody's pain in 3 or 4 appointments. You should be able to do that. But this is where people mistaken pain gone versus I'm 100% better.
mhm.
Pain gone. Yeah, okay, my pain, but now you're going to go load it and you're going to do the sport again or do the activity. Now it's back because you didn't condition and retrain the body to be more resilient to that trauma or to those forces. So guess what? Now it's back. The research actually shows it's 8 to 12.
Yeah,
And part of it, and it's really interesting because people who got less than 8 were not satisfied. They kind of gave a low score, and people who got more than 12, they gave this kind of low score. And the part of the reason is they didn't feel 100% taken care of. They felt like, well, if they get less than the 8, they weren't 100% heard. They weren't 100% taken care of.
mhm.
So there's a psychological component. And then anything more than 12, they're like, oh, well, they just keep wanting me to come back. But that kind of 8 to 12 is kind of like that magic number where, you know, we know that tissues heal, muscles adapt 6 to 8 weeks and tissues 6 to 9 months, 100%,
Mhm.
right? Depending on the tissues, size of tissues and whatnot. But kind of like that 2 to 3 month window, especially if you start spacing them out, like people they're good. Like,
Mhm.
yeah, you know enough, you're strong enough, you can go do the thing. Just keep strengthening and progressing, you'll be fine. So it's kind of like it falls within that physiological adaptation model as well as a psychological I've been taken care of model as well. So
Well,
it's really interesting.
that actually follows if you actually read their research,
Mhm.
their own research. It's in there,
Sure.
but they use the 3.4
Right.
because insurance. Um,
Mm.
Insurance is a big deal, particularly in the States, and insurance
Right.
companies won't pay for more than 30 minutes.
Gotcha.
So they had to use that number in
Yep.
order to go to the insurance companies one at a time and say,
Right.
hey, we'll get them better faster. You'll save money. Um, and, but you will pay us. You will pay us for an hour long
Right.
sessions because that's what
Right.
we do. And they work like you. As a
Mm.
business model, of course, I do like the idea of people customizing, like actually using their knowledge. But as a business
Sure.
model, they have a policy of it's always 30 minutes of soft tissue or pain relief type
Mhm.
treatments,
Sure.
and then 30 minutes of exercise, at least 30 minutes of exercise per session,
Right.
because it's movement. It's got
Right.
to be movement. It's got to
Sure.
be strengthening. It's got to be coordination.
Yeah.
And they do get people better more often because as a
Mhm.
business, they have
Yep.
that type of model.
Sure. Yeah. Yeah.
Um,
Ours are all like, we do 30 minutes. Oftentimes we have modalities, we have PMF and we do acupuncture and we'll put people on that after, the therapeutic side. But then they're on another, like they'll come in for an hour with one of our PTAs and whatnot and work one-on-one and do rehab exercises.
isn't it? So one of my mentors, you can't always do this, but he showed something to me in that if you can get rid of someone's pain through a self exercise, a self
Yep.
stretch, and
Yes.
like you said, oh, if I activate all the muscles, all of a sudden
Yeah.
the pop click is gone,
Yeah.
the pain is gone. That's often a light bulb moment for them.
Yeah.
That moving is the way out.
Yes.
I love the Mackenzie. I'm not sure how many disc
Yeah.
people you see.
Oh yeah. We see lots.
Yeah. And so of course, before it was like, okay, chiropractic adjustments, hot pack or whatever, and then maybe an exercise or something. No.
Mm,
First day, before I even touch them, go straight into it. If it's pain relieving, I don't
mm,
have to tell them to do the
yep,
exercise. They
yep,
will do the exercise
yep,
all the time because the exercise reduces pain, and
yep.
they can feel it themselves. It's something they can do. So, but if I get them out of pain first, they don't feel that benefit. They're reliant on me and not
Yep.
on the movement, not on sort of
The manual,
self-reliant.
the touch. Yeah.
Yeah.
And this is also why it's so important that we understand, well, what's optimal range of motion?
Mm-hmm.
Someone comes in and they have a straight leg raise of, active straight leg raise of 90 degrees. I'm like, you don't have tight hamstrings, right? Oh, it feels so tight. And then you start muscle testing around, like, well, you have deep hip rotator, or you have weak deep hip rotators, and you have weak hamstrings, and you have a weak hip flex. Like, there's so much weakness around there. I'm like, we need to strengthen this. And as soon as you start applying, some control exercises, all of a sudden, well, that tightness is gone. So, and again, the manual therapy, if someone's, if I can get the foam roller or something in there to release a lat, or kind of change the inputs around that to get it relaxed, and all of a sudden they have full shoulder flexion, great. I show them how to do it on their own,
Mm-hmm.
pain-free, and now let's go hang off something so that we can set that overhead position. But sometimes, using a needle, it's a quick, it's a shortcut, right? Like, we can get in there and we can release something really quick, or get it to just at least relax, and also in the range of motion. Great. I'm going to go show you how to do this at home now, so that you can keep this range of motion, and then we lock it in. So yeah. I'm not opposed to, like, again, and the expectation for people, like, when they're coming in to see us, they expect to be touched. And that's okay, right? And we don't have to do it too much, as long as we don't rely on it and make them real dependent on it. So it's like, yeah, let's assess stuff. Okay, yeah, it's a little tight here, but I'm going to show you how to do this on your own. Okay, great. But at least you set the expectations, and they got their expectations of, okay, I got some manual touch, and it wasn't just movement exercise. Because we've had a couple of clients who are like, oh, well, I didn't get any hands-on manual therapy, and their expectation was this. Well, did your pain go away? Well, yeah, it got better. Okay. Sometimes it's just like, let's take care of the psychological component, but then we add in the other component of, you're going to take care of this on your own too, because that's the end game too. So, yeah.
So I'm going to jump to recipes. And I've talked with a lot of people about this, patients and physiotherapists, particularly young physiotherapists just coming out of school, and chiropractors just coming out of school. Like, the school I went to was heavy rehab focused.
Yeah.
And if you look at the research in exercise, if you look at healthcare research, there's not a lot of research in exercises, because there's no drug money in it. So at best case scenario, you're lucky to get 50 participants.
Right.
And then if you are going to do a research study, are all the patients have the same problems? You don't know.
Right.
I don't really trust whoever doctor did the diagnosis, that's an accurate diagnosis. And so everyone has different muscles that were weak. Maybe one person has a hip drop, one person can't internally rotate the hip. Who knows what's wrong with them, but they are all diagnosed with hip pain. We don't. So who knows how they're going into these studies, whether they have the same diagnosis or not. And then, because it's a research program, the exercises are quite rigid.
Right.
10 reps of this one, 20 reps of this one. No room for play for the clinician. Okay, try to rotate the foot in, rotate the foot out. No, we have to add a force from the outside. No, none of that. It's rigid. And then they take an average at the end.
Yep.
Some people got better, some people got worse. Maybe the average is no result, or the overall people got better, but some people got worse. You lose so much. You can't. And so anyway, the research protocols get into the schools because there's research behind them, and there's this recipe book that they're taught, and it's this problem, again, anatomical diagnosis.
Yeah.
These are the exercises you do, not why or if this is this way. It's and I see people, and it's like, if they're not getting better, they just like, okay, we just need to do more.
Right.
They've run out of options. This is the protocol I was given. Like, what are your thoughts, and how did that inspire maybe your creation of your program?
So this comes back to creating consistency on the front end with the assessment, so that you can have creativity on the back end with treatment. It's reversed. It's like everyone tries to get creative with their assessment, and then they give everyone the same protocols or recipes. Oh, you have hip impingement? Well, here's the protocol for that. And like, it doesn't work that way. Like you said, you can have 10 people with hip pain, kind of a similar diagnosis. But what is pain? It changes behavior. Well, what's movement? It's behavior based, because they're going to create their own compensations, and it's completely the independent per individual.
Mm-hmm.
So everyone's going to respond to pain differently. They're going to have different dysfunctions. They're going to have different anatomical variations. So without the assessment on the front end to find out what they can do, what they can't do, or what the deficiencies are, you can't tailor exercises on the back end. It's like you're throwing a bunch of exercises at the wall. Hopefully something sticks. And that's what these research studies are doing. And it's a problem because there's too many variables, and there's too much independent specialization that is required for every person, and they're trying to fit everybody into this set of exercises. Mm-hmm. Well, how come it's working for these ones and it's kind of working for these ones, but it's not working for these ones? Well, because they're all completely different human beings. Mm-hmm. They have a similar diagnosis, similar pain presentation, but they have completely different behaviors and anatomy and conditioning and motor control. And their nervous system is just trying to survive around that pain as best as it can. It's like trying to assess gait. People are like, oh, you have a Trendelenburg gait. You have a weak glute medius. I'm like, what the hell does that mean? I'm like, they're performing the thing, which is walking, as best as they can. Now, until you start breaking down some of the prerequisites, can they even stand on one leg? Yes or no? Mm-hmm. Oh, when they have this Trendelenburg on the right side, well, they can't stand on the left. I'm like, well, that's a problem. So they're obviously hitting the ground differently on the right and left. Mm-hmm. So then you start looking, they have neural tension on the right side. Well, no kidding, because they're compressing the lumbar nerve roots, which is causing this APT, which is then inhibiting the deep glute hip stabilizers, and they can't get access to the glute. So, the pain's over here, but the problem is actually on the left side because they don't have motor control over there. And it's causing all this compression issues on there. So this is where we look at, too often people, it's like, squatting, walking, and they start throwing random exercises at people. How do you know? Like, that's the end game. There's so many things going on there, and they're just trying to move to survive. They're trying to avoid pain and get the job done. Now, unless you start breaking out the pieces and finding out where the problems are, you don't know what's driving the problem. Is it nerve compression? Is it the neck? Is it the hip? Is it the foot? You don't know. So going back through the system, again, being consistent on the front end, looking at everything as a system first, find where the problems are, and then go on the back end and start fixing those issues. Mm-hmm. And then go back up through those motor patterns, retrain them, and all of a sudden, their gait is better. Well, all they needed to do was learn how to roll to the left, right? Because we found this rotation control issue. They didn't have this reflex control to the left side that was causing this left stance inhibition. And they just couldn't feel how their pelvis was supposed to roll through and spin through the air.
Isn't it magic how you point out something and you need to do this, and they're like, oh, what? You're right. My body won't do it. Why won't my body listen to me? Yeah. Well, that's what we need to work on.
Right. It's reflex. Like a lot of it's all subconscious. 95% of what we know is unconscious. 5% we're aware of. And people trying to consciously fire up their glute with running. I was like, that's not how this works. You should just be running.
Yeah.
Like, you shouldn't have to crush your glute. But now you're creating this weird mechanic, and then all of a sudden your knee hurts or your back hurts.
Yeah. A lot of people don't realize that you can't force a muscle pattern. You can't force a muscle habit. You can't change it by force, because the information and the processing happens in different parts of the brain.
Yeah. You got to feel it.
Well, we have our cerebrum, our conscious mind. And anyone watching or listening, you should look up a picture of anatomy of the brain on YouTube. I'll put up a picture of the brain here at this point, because you have the main brain, all your memories, pain processing, the final step of pain processing, and all your conscious thought. And when you ask muscles to do something, you really ask for a certain movement. You don't necessarily ask for a specific muscle to function. And then at the back, we have this cerebellum. It looks like a smaller brain. And that's what controls your muscle habits and your walking and your posture.
Rate, rhythm, force, and accuracy.
Yeah. And it's a second little mini brain.
Yep.
There's one great story. I'm not sure if you've heard this one. I watched the video of this case, and it was someone where the eyes weren't connected anymore. It was some sort of tumor or
Hmm.
a stroke or something that wasn't connected to the conscious mind, so he couldn't
Mm.
see.
Yeah.
But the eyes were still connected to the cerebellum.
Yep.
So the doctors put a whole bunch of obstacles in the hallway, a vacuum, a garbage
Yeah.
can, spread all sorts of things all over the floor.
Yeah.
And they said, okay, we have you in the hallway. I'll ask you to just walk down the hallway. Just walk down the hallway. And of course, he's contorting his body and
Yeah.
twisting and stepping over things.
Yeah.
And they're asking, you're walking a little strange. Is there some reason you're walking like that? I don't know. It's just this just feels like my normal. Like it feels like this is just the natural walk I should do
Sure.
here.
Well, it's interesting. The cerebellum. It's such an like that's where we learn movement. Like that's where we correct. Like I said, rate, rhythm, force, and accuracy. We move, we make a mistake, goes to the motor cortex. No, that wasn't the right plan. Let's re-execute that.
Yeah.
That's where we first learn to move. And we do it through watching. Kids will watch and repeat and mimic. They also feel the environment. So, it's 10% of the brain, but it's 50% of the neurons.
Mm-hmm.
So like that tiny little movement brain, I call that the movement brain because that is where movement happens. That's where it happens from a reflexive perspective. This is where it happens from a motor pattern perspective. And then once it's calibrated at the cerebellum, then it's stored in the motor cortex for later, right? So it's so cool because when you work with kids, and they have these kind of faulty patterns. You go back down to some of the primitive things. They can't crawl, they can't roll. There's some trap reflexes, the moral reflex. We get them rocking, rolling, getting inverted. All of a sudden it clears up because we've stimulated the cerebellum. It reorganized the nervous system and wrote new patterns. But coming back to the visual system, we see a lot of concussions. And when we look at certain eye movements, we know that the eyes are highly connected to the medial cerebellum. So if somebody can't converge or they're having smooth pursuit issues or saccades, I'm like, okay, we have a medial cerebellar issue. But then we start stacking up cerebellar tests. All of a sudden, they do a Fukuda, they're rotating to the left. They fall to the left, saying so you start to tie in. Oh, okay, like there's some motor control issues that are from the cerebellum down, but also from the eyes into the cerebellum. So you can start to pick apart, which systems are faulty and then start to reconnect them. And the great thing with the cerebellum is once you understand its connection with the inner ear, the central spine, and all these other reflexes, then you can start to tap into some of these exercises and tie them all together. And all of a sudden you start to get really cool, dramatic results. And not just from a rehab perspective, but from a high performance perspective.
Yeah.
And all of a sudden your athletes, they start lifting heavier right then and there. They can jump higher. And they're like, what just happened? I'm like, we unlocked your potential because we tapped into some neurological things that just weren't as connected as you thought they were. And because they perform at such a high level, they see a really dramatic change. And all of a sudden they're like, I'm squatting heavier weight with no pain. Awesome. Because we got the nervous system organized a little bit better. But it made a dramatic change because they are performing on that threshold between high performance and injury. So all of a sudden their performance starts to go up. It's really, really fun. And then with kids, they just respond so quickly. I'm like, 2 appointments, you're good.
So we talked a lot about importance of touch, importance of pain. We talked about movement, and we've been talking about the right assessment. But for the audience's benefit, the way I work is I max out insurance after 15 minutes. That's why most chiropractors on island don't work for more than 15 minutes.
Sure.
Because you don't get paid for it.
You don't get paid for it, yeah.
I only took this job here. Well, actually moved back to the island for the wife, but only took this job here. And I was a bit of a jerk in the interview. I'm only going to work there if I get at least 45 minutes per patient every visit. Not first visit, every visit.
Right.
It's like, okay.
Right.
So it's not profitable to do so necessarily, although the cash, we do charge a little bit more for it.
Sure.
But I use every visit is an evaluation visit. There has to be evaluation.
Has to be.
Every
100%.
Visit.
Yeah.
And good therapists, I've noticed that's a trend with good therapists. It's constant reevaluation, constant modifications, constantly pushing to better. It's never the same every time.
How do you know if you're making change if you're
Yeah.
not checking your work?
Yeah.
Like you assess, you intervene, and then you reassess after the
Yeah.
treatment. Did it make change? Did it make meaningful change? And can the patient see and feel the change? Because that's what really matters. If all of a sudden, they're like, oh, I can't touch my toes, I have back pain. And then we do some stuff on the ground.
Oh, yeah.
And all of a sudden they're like, I can touch my toes. I'm like, magic, right? Now they bought in. Now they're like, okay, you're going to do these homework exercises at home now, right? Because it made a change. If you don't show them what your findings are, and then you don't show them the change, they're like, I think I feel better, but you're telling me I'm better. And maybe I come back, maybe I don't come back, right? And complete the treatment plan to get 100%. They don't know. But like you said, if you're not reassessing every single appointment, how do you know what you're changing that day? Because it changes every day. Mm-hmm. We're dynamic beings. We're doing different things every single day. And the nervous system will reorganize differently almost every single day. I'll give you an example. I had a power lifter and he had this, he'd always take like 30 minutes to warm up just to squat. And the one day he comes in, assess, okay, certain muscles aren't turning on. We did some hip mobs, gave him 2 exercises. Like, okay, do these 2 exercises, squats. He's like, oh, that feels awesome. Took 5 minutes to get into a squat position. He does that all week. Comes back to me next week. He's like, I was doing the exercises you gave me and it didn't help. What's happening? I said, let me guess. Last week when I saw you, you bench pressed before you squatted. And I said, this week, let me guess, you deadlifted before you squat. He's like, yeah, how did you know? Because you reorganized the nervous system in a different way. We need a different lock. You've got a different lock. We need a different key. So because he loaded the body in a different way from one day before squatting and another day before squatting, it changed his nervous system and his muscle patterning and his firing, and it didn't get the same outcome. So I'm like, okay, when you deadlift, here's your self-assessment. If this doesn't move, you can't do this. Here's your keys, right? Very simply, I give my athletes a form of self-assessment to see what's not moving, what feels off.
Mm-hmm. Oh, yeah. The patient is the only real specialist in themselves. I like to say it's a collaboration between specialists. Yeah. And I think, let's say the bad clinicians, get the bare minimum. But people, I feel like my pelvis is twisted, or there's something tight on the outside of my legs when I squat or something. Right. And that intuition can be very, very helpful.
Sure. But giving them something to, I put together kind of like a little mini course for my athletes. Mm-hmm. I use this with my NHL and my alpine skiers. And they would go through what's called the self-awareness movement scan, SAM scan. They would check cervical flexion. Can you do it? Yes or no? Pinch, pull, pain. Mm-hmm. Look up, any pinch, pull, pain, rotation. Okay, good. Touch your toes, back bend 3 feet from the wall, side bend, single leg balance, shoulders, and then straight leg raise and open the hips. If anything feels off or something doesn't feel right, they have now the exercises to correct those issues. So we're taking care of this kind of baseline movement competency and symmetry before they start loading it, before you start kettlebell swinging and squatting heavy weights and skiing, because these little imbalances that we can kind of create over time, if we leave them unchecked, they can cause an injury somewhere else. But when the body's balanced and it moves with more symmetry, then there's less likely an injury is going to happen. The one thing I learned is the body doesn't manage imbalances very well. It doesn't manage torque. Mm-hmm. So if we have a tight hamstring or some nerve mobility issues on one side and somebody's bending over to deadlift something, well, guess what? They're hitting tension on that side sooner. It's going to create a twist because the body's going to try and take the tension off that nerve. And all of a sudden they blew up a hamstring, or they tweaked their back, or they did something else. Well, if you screened that first and caught that nerve tension and flossed that out and then cleaned up that toe touch, no issue.
There's a research study done. I forget what book she wrote, and I forget her name, but it was something about core stability. Mm-hmm. And so she had done a research study where they were looking at basically low back proprioception, and I think it was basically proprioception and ability to react to changes. They had 2 measures of that, 2 objective measures of that. Proprioception is a sense of where the body was. So she'd have their eyes closed and would twist them, and they would have to untwist to where they were before. Mm-hmm. And the people who scored lower in proprioception went on to, she was doing this with athletes, went on to injure themselves. Was what, like a 300% increase in injuries in the people with bad proprioception in the low back.
Yeah. Because they're mapping, their kind of neutral position or their mapping in the brain is off. So anytime they're striking or loading, they're setting up in what they think is neutral, which is a slight rotation, and then they're loading it or they're performing their high skill in that position. Well, the position sets up the pattern, and the pattern will predict power. If your position's off, your pattern's off. If your pattern's off, the nervous system's not going to give you power. And all of a sudden you try and generate that power, something's going to fail.
Well, she had some great videos that went along with it of people, doing a one-legged, jump off of, a physiotherapist table.
Yep.
And the people who scored well, knee landed, no issue. People who who scored poorly with back control.
Yeah.
And they landed, whole body twisted, knee went inwards.
Yeah.
I was like, oh, ouch.
Yeah. So coming out of when I got out of the hospital last year, I was all twisted because I was bedridden for 5 weeks. And I saw my osteopath friend. He worked on some fascial stuff. Physios would come over, work on me. And then I saw my chiro friend, he kind of, we'll call it straightening me out. But like my toe touch was, I could put my palms to the floor, pike the handstand before. And I couldn't get my fingers past my knees because I was crooked. I was side bent. So when I was strong enough, he went and did some adjustments. All of a sudden I can touch my toes. Great. We put the spine in a position that felt safe. And my nervous system said, yep, I'm going to let you go here. So now we can touch the floor because the muscles, the nervous system was organized in a bit better way. That day, so before I was trying to lift 50-pound kettlebell off the ground, struggled. That day after I saw him, I could do 160 with 2 kettlebells, no problem. So I use that as an example because by taking the brakes off, by putting my spine in a more optimal position, my nervous system was more organized, it relaxed, and it took the brakes off. Because the nervous system's a brake system. Mm-hmm. When it doesn't like something, it feels pain, puts the brakes on. It inhibits, it creates tightness, it creates protection. When the nervous system likes what we do, takes the brakes off. We got more power, we have more mobility. So this is where when we use movement, that's why I said neurology, when we use movement muscle testing to know if we're effective, if we applied the right input, manual therapy, needling, exercise, well, the brain says, oh, I like that, takes the brakes off. All of a sudden, more movement, less guarding, more coordination, more balance, more power. So it's fascinating because, just by using movement and muscle testing, very, very simple, range of motion, those are your feedback loops for effectiveness. But if we don't check that, then we don't know.
I thought of another case that went beyond what I could do in the room. This particular individual, severe childhood traumas. So it wasn't just the nervous system scared of a certain movement. It was almost scared of the entire world. Yeah. Eventually, I had him go to, we mentioned bad physiotherapists, not modifying, or just not the exercises weren't right for that person.
Yeah. Yeah.
And so I encouraged him to mental health counselor, to mental health counselor, to mental health counselor. Finally found someone to get a breakthrough, and he was on disability, and I could finally make progress when his body wasn't subconsciously scared of the world.
Yeah.
And all of a sudden, I think I had one treatment, and he's feeling stronger. And the treatment after that, he says, yeah, I got a job now. Pain's totally gone. I'm getting stronger all the time. Another story I'll mention based on something you said about all your talk about increased performance and people feeling a difference. And one person comes in for knee pain. So first visit, he's doing stairs funny. So we have, we're trying to correct his ability to what his habits were with stairs. And what happened was he comes back the next session. And so how are things going? Well, a lot less knee pain, but my hips, they hurt. It hurts right here. I was like, does it hurt like a muscle soreness, like you worked out heavily? It's like, yeah, it does feel like that. Do you ever get that, like using new muscles?
Yeah, we switch stuff on. You're like, that's called muscle soreness. Those are muscles that haven't worked for quite a while. but your knee pain's gone. But muscle soreness is okay,
Yeah.
especially around the hips. You're using your glutes. Welcome to your glutes again. So
Yeah.
you may not have been driving, your lower extremity for the longest time.
Yeah.
But yeah,
Um,
it's fun. It's fun.
it can be so much fun.
Yeah.
Um, so we need to wrap up soon. I'll have a few things to say. So you have a website, www.amtcertified.ca, right?
Yes. Yeah. Yeah.
So if people are interested, I understand you also have a free mini training,
Yeah.
Master 8 Neurohacks for instant client improvement in 60 seconds.
Yes. So this is something that it utilizes, again, breath work, cerebellum activation, visual, proprioception. They're quick. We use a quick movement assessment. And then these are quick inputs that you can apply to clients to give them strategies to move better quickly and help reduce their pain. Now, just like anything, if it's a hack, it might be short-lived. Unless you find out the true cause of why someone's not moving or moving a particular way, the effects might not be very lasting. But they are some good strategies once we find through a full assessment, once you find through the assessment what the problems are, well, you can apply these. But it works really, really well. And I would do this at conferences and watch people start moving better immediately. You got these clinicians and whatnot. They're like, okay, well, what is this? And all of a sudden they're like, oh, I just did some tapping on my legs and I can touch my toes now. I'm like, well, we just improved proprioception, right? So very quick, 60-second little hacks, try them, apply them tomorrow. So it's there for anybody who's interested, and it gives them a little bit of taste of how powerful neurology is.
Do you have any last message for the audience?
Yeah. These are professions where people come to us for help. And the great part, with what we do is we can go learn a bunch of new things. And I encourage people to go learn as much as possible to have more tools in their toolbox. Just have a way to organize them so that you can be more effective with them, but never let go of that, desire for curiosity, and keep that beginner's mindset. Because, when we're early in our careers, when thinking back, I'm like, there was no more time I was more excited than learning something new. And we can get stuck doing this 20 plus years now. It's easy to get stuck in our ways, but always keep an open mind and keep learning more things, and then try to understand, well, how does this fit in my paradigm? And if it's having a positive effect, why is it doing it? And once you understand the why, then you can start to make more sense of what we do.
Well, thank you so much for being on the podcast.
Brandon, thanks for having me.